Welcome back to another episode of Sports Medicine on Tap. My name is Brandon Olai, and I'm sitting here at Neck of the Woods Brewing Company in Pittman, New Jersey with my good friend Dr. Frey. Dr. Frey, how are we doing?
Spectacular.
We have a special guest tonight and a new guest, which is always fun.
Guest.
So, Dr. Frey, who do we have on tonight?
So we brought on one of our new primary care sports medicine docs. The virtual reconstructive orthopedic sports team is growing almost by the minute.
There you go.
And we've had a new few docs join the fray, so to speak. Yeah, you like that. And so welcome to the show for the first time. We have Dr. McKensie Wahl. She used to run track at University of Delaware, and avid cyclist. Until fairly recently, injuries get in the way. She went to Jefferson for med school. She did a residency at Drexel, family medicine residency, followed by sports medicine fellowship at Crozier. Here to talk a little bit about one particular injury that we've talked about before. But yeah. Well, welcome to the show.
Yeah, thank you guys for having me. I'm excited to be here.
All right.
That's awesome. So we're going to get into it a little bit tonight, and ironically, this is the Tuesday after the Super Bowl, like we always say. We record on Tuesdays.
End of the NFL.
The end of the NFL. It's a long 200-some days until.
What a game.
Right? Great game. Not so many injuries, but a couple weird ones, which we'll get into. And, ironically, we started the NFL season with a big injury, and we're ending it with the same thing. We're going back to the Achilles again. And here we are, and just a little recap for anyone who didn't view the Super Bowl and may have missed this. It didn't really happen in the field. It happened on the field of play, but didn't happen during a play. Yeah. In the second quarter of the game, one of the 49ers linebackers went to go run onto the field like he's probably done a bajillion times in his career, and he felt a pop in his left leg, and he went down, and that's all she wrote.
That's the game.
Yeah.
So interesting, right? Like we kind of dove into the whole Aaron Rodgers thing to start the year. We went in depth with that. We had Dr. Brand on.
Similarities, a little bit eerie.
A little bit, and I think with the background with Dre Greenlaw Dre Greenlaw, excuse me.
That's right.
He was kind of bouncing on and off the injury report with a little bit of Achilles tendonitis leading up into the playoffs. So
in Aaron Rodgers' case, they called it a calf pain, calf strain.
Yeah.
And again, we have the disclaimer every show. We don't have access to any of these guys, their actual medical charts, or medical information. We're just going with public information. So we don't know if it truly was calf pain, calf strain within the Aaron Rodgers situation. Right. But suspicious that it could have been more of an Achilles tendonitis.
Yeah.
Right.
And now
we're here, right?
Right.
And I think that's what we're gonna spin this episode a little bit tonight. Again, we don't know exactly what he did, but we're gonna talk about some treatment options and other different things that maybe led up to this, or we have some other historical references that has happened in this situation of different things. So
It was the year of the Achilles, I guess.
It's the year of the Achilles.
Yeah. So I was just talking before the show, right? I saw a thing on online today about Achilles tendon ruptures. And there was about 23 or so this year across the NFL, which is crazy, that's a lot.
It seems like a big number to me.
Almost one per team.
Right.
So about 23 of them. And I think this year in particular, there's been a lot of debate about the grass, the playing surface, the grass, the turf.
Always a debate.
Always. I think it's going to be a forever thing.
Ankle sprains, ACLs, Achilles tears.
So according to the sources that I looked at, I don't really know if this is true or not, but they said about approximately 14 of those Achilles tendon ruptures happened on grass and about 9 of them on turf. And 7 of those, which is almost a third of the total, were in linebackers.
Man.
And Dre Greenlaw is a linebacker.
So wait, 14 on
grass and 9 on turf. Did I flip that?
Or no, you got it right.
Okay.
You would think that it would be flipped, because typically it's the turf that's the issue.
Right. Everyone's all concerned about the turf.
Right.
And it's just, I don't know.
Is it? And typically we think about like kind of the push off that moment. You think if they're able to grip better, which typically you can do on turf, it's counter. It's counter what you would expect.
Right.
Could it have something to do with, I was going to say unevenness of grass, but like those fields are pristine. There's not a lot of unevenness.
And I mean, I think last year there was some speculation about the field conditions in the Super Bowl, but then it's like at the end of the day, it's still the Super Bowl, right?
Oh,
it is the epitome, the peak of the NFL season. You would think they have the best surface to play for.
Right.
And last year and this year, they both played in stadiums where they roll the field out and they roll it in for game time. So you think it would be in good conditions.
You would think, right?
You would think.
It's funny. So we're always kind of debating our topics, and there's I think a very good ski topic. that Dr. O'Donnell had supplied us with, it, which is on the horizon. But I figured that the timing's right here for this particular one. And so I got a text message by another one of our primary care sports medicine folk, Dr. Holmes, who's kind of the main man, and he presented exactly this question. He's like, did you see that? Like, what do you think the chances are, the possibility that he'd gotten a cortisone shot?
Yep.
And I was like, I have no idea. I was like, and he's like, what makes for a good show?
Yeah, right.
And I was like, you're right. It does. It's good. It's good banter. It's good fodder. Like, we have no idea if you actually truly did or not. But what happened in the past?
Right. And I think that's where we take this idea of the cortisone, right? It's like, we've kind of seen this before as the Philly fan base, at least in general. About 10-ish years ago, the Ryan Howard Achilles rupture, right?
Right.
There was simple. He went for a swing, tried to run down first base, never made it. He only made it about 5 steps off the plate, and it happened. Yeah, it was about 10 years ago or so, because I remember I was still in school and I was like, oh, he just said he felt like he got shot with a gun in the back of his leg and nothing happened. He thought, if I'm not mistaken, in his postgame,
I think it's more than that. I think it's like 15, whatever. Anyway, sorry.
Yeah, but no, he swung and he said, I thought my back came around and hit me in the back. And it's like,
that's what they all say.
That's the classic.
Yeah, it's a classic.
History.
And I was like, oh, dude, that doesn't sound good. And then there was some speculation about his treatment going into the game, and apparently he had a cortisone injection into his ankle region.
Yeah.
For
retrocalcaneal
for bursitis. Apparently was an ultrasound guided injection into the bursa, and that they did it because of all these things. And there he goes, tears his Achilles, and I mean, some can argue that it altered his career and kind of ended it in a sense.
Altered, I think you can argue it was the beginning of the end.
Yeah, so that was kind of brought up the topic, right? It's like, we've seen this before, maybe it still happens, but although it's not a popular treatment option, right?
Right.
It's definitely fallen out of favor.
Why has it fallen out of favor as an option?
I think over the years, since Ryan Howard, we've seen more tendon rupture after any type of steroid injection into a tendon, especially landmark-based or a blind injection is what we call it.
Yeah.
Sticking a steroid into who knows where can weaken the tendon, and then if you continue to practice play on it, that risk of rupture increases.
Sure. Yeah. Presumably, you're right, I guess, and especially, they did say that one was ultrasound guided, so it wasn't this, like you said, blind, sort of landmark-based injection. Theoretically or presumably, they're not injecting into the tendon, but more around the tendon. Is there, and there may not be an answer to this, and I kind of have my own little theory, but it's certainly not based in science. Is there a reason in particular why the Achilles is a little more susceptible or worrisome? Like why is that like the big no-no, those injections in that area?
So not to get too into the nitty-gritty, but so the Achilles tendon is made up of part of your calf muscle, 2 parts of your calf muscle. They come together and attach into your heel bone or your calcaneus.
Sure.
There is a spot maybe like 6 centimeters above where it attaches into the heel that doesn't have great blood supply. And when there's not great blood supply, the watershed region, and you put an anti-inflammatory, it just is a bad mix.
That's exactly my theory.
That's
it.
I don't think I'm alone with that theory. But and it's kind of notorious, like just not an area where you want to put cortisone. But so I guess theoretically, like docs that are treating them, these are good docs that know this, and at some point it's not a guarantee that like if you try that, if you do that injection, that this person's going to wind up with a tear, right?
Yeah.
Like, so I don't know. Is there value? Is there some point in the Super Bowl, let's say, where you say, maybe it's worth risking it. Maybe it's worth trying the shot. How old is he as in his career? I have no idea.
He's about 26 years old. I think he got drafted in 2019, so he's
Pretty
about
young.
5 years in.
Yeah.
But it's interesting too. I was talking to one of my coworkers about just him as a person, right?
Sure.
He's almost fits the mold, right? He's a male. He's a little bit older.
But 35,
Right.
40 is
But
the
yeah,
typical.
still young for this.
But he fits the weekend warrior mold if you think
That's
about
true.
it, in a sense of the last month of
Are
his.
you criticizing his practice and his training?
Yeah, 100%. Right? Think about it. He doesn't really practice that much.
Oh, I see
He's
what you're
limited
saying.
in practice all week,
Right.
and then he goes 0 to 100 for the weekend on
Right.
Sunday to play in the biggest game of his career,
Right.
and then these injuries happen.
So before we go down, kind of define like what do we mean by weekend warrior? What is a weekend warrior?
More or less like the middle-aged person who just does everyday life, 9-to-5 life, and then gets some free time on the weekend and wants to go for that
goes
long.
Bonkers.
Goes crazy and goes, wants to go play in that.
Some rhabdo at the end of the weekend.
That's right.
Oh, yeah. Go play in that rec game of basketball at the local gym or other
Yeah.
things like that. And that's where those injuries happen.
Yeah.
And that's where it kind of that idea of like, he was limited going into the NFC Championship game. Wasn't really practicing that much on a limited basis. And I don't know. Yeah. I have no idea what limited means in the NFL. It could mean you just show up and you walk around a little bit, but you're on the practice field, so you're limited. Yeah. Or you do certain drills and you don't do it. I know what it means for my athletes and stuff. So it's a little different, obviously.
Right.
But a limited or reduced workload going into it and then picking up that workload at the end of the week, is just kind of like that model in a sense.
I feel like if you've been doing it for years,
right?
You've earned your weekend warrior title. Right. But if you missed, the last 3 weeks or 4 weeks, it's still in pretty damn good shape.
Yeah, I would say so.
Oh yeah.
But you're right. I think you make a good point. Like he wasn't doing as much. He's trying to nurse his injury at that particular point. Again, we don't know if there was an injection involved or not.
Right.
And then, but the way that he did it, like
so weird.
Yeah.
It's crazy to watch. I mean, it was a good camera angle for that. And I said to my husband sitting there, I'm like, there's no way he did not tear his Achilles right there.
Yeah.
And he's like, no way. And then they announced it maybe 5-10 minutes later in the game.
Right. Right. What was the reverberating? Remember that one? Was that also Achilles?
Yeah, the reverberation.
That was actually Aaron Rodgers, wasn't it?
Yeah,
Where the reverberation.
It reverberated. Yeah, it was like the big thing when Aaron Rodgers went down. Like all media outlets did. That was like their favorite key term. Reverberation. Like reverberated. You saw it.
Yeah.
Like, all right, we get it. And like you can go back to the Kevin Durant one where you saw that one pretty well. That was pretty good and other things like that. And like you said, the camera angle, it was literally right behind him. And it was just so
Was
weird.
it scripted? I don't know.
Yeah, right?
Planned for drama.
Yeah. And it's just weird because it was also just interesting. Like he just did a couple bounces like I'm sure he's done a bunch of times. And then he just put that left foot back to go step. And then that was it. He made it a couple feet and then fell down.
It makes you wonder because the setup for Achilles tendonitis or Achilles rupture is either an abrupt change in activity, increased level, or chronic overuse, chronic microtrauma. So was it him jumping back into the games after that limited reserve like you were talking about, or just constant through the playoffs?
Yeah. Right. Who knows, right?
Yeah.
That's And it would be interesting to know, and of course we don't have access to this, like was there swelling in his Achilles at that particular point?
Right.
Is there a nodule? Is it like some of the things that we start to see when people do start getting more of these chronic tendinopathies and can take a little while to get him under control and to get him down. And I think that's what becomes sort of the appealing thing about the idea of trying to use a cortisone injection to calm that down. Like it's you have a lot of swelling there, you have a lot of inflammation. We can get rid of that inflammation. Your pain will improve. You'll get better. And I almost wonder, is the increased rate of tears a byproduct of reduction in the pain? So you have a reduction in the protective effect, and then they overdo it, they overstrain it, or is there a molecular level issue with the inflammation and injecting into that watershed area, like you were saying, that just leaves it more susceptible?
Yeah, I don't know if there's an exact answer for that, but I would say a little bit of both between the tendon weakening with the steroid and then you're feeling pretty good with the numbing effect of it. Just a bad combination.
Right.
I think that kind of happens a lot in football, particularly, especially in the NFL, right? Like a lot of these guys do take a lot of different medicines and anti-inflammatories and stuff just to get through the brutality of the game.
Right.
And like for example, my wife and I just watched the Kelsey documentary like 2 weeks ago, and he was talking about it. And for 2 years, when it was done, he was like, the season's over. I haven't been really taking any anti-inflammatories, and man, everything hurts. Like it's just hard to move around. And he's a little older. He was in mid-30s and whatnot. But still, just like when you're in the motion and you're just kind of in the momentum of the season, you're not like you're getting your medicine, you're doing this, you're doing that, and you're going through the game. And football hurts. I think I say it all the time. Like I was like, what? I mean, when someone gets hurt playing football, I'm like, what'd you expect? It's not like a feel-good game. You get hurt playing football 9 times out of 10. It's just kind of how it is.
It's part of the game.
Part of the game, exactly.
Yeah. And it's part of the badge a football player wears.
Yeah,
right? To be able to play and play through the pain, and play through these other issues. We mentioned ultrasound-guided injection, right? And that's what Ryan Howard had when he had that particular injection, and then you mentioned the difference between ultrasound-guided versus laminar. What's the advantage? What exactly are you able to see, and what exactly are you doing with the ultrasound, and what is the theoretical advantage to utilizing ultrasound when you do an injection? Because you do a lot of these injections, right?
Yep, I do a lot of these.
You do a lot of ultrasound guided injections.
Yes, exactly.
Not Achilles injection.
Not Achilles injections. The advantage of it is you have the ability to know, pinpoint exactly where you want the needle tip to be. I mean, landmark injections, they've done studies for the knee, you're like 80% accurate, but if you have 100% accuracy for a patient you're caring for, why not have that extra 20%?
Right.
Why not be sure, right?
Yeah. And the other interesting thing with Achilles or any tendinopathy, with the ultrasound, you can see changes in the tendon.
Right.
It becomes thickened, it becomes disarrayed or disorganized.
Right.
And then more chronic tendinopathy, you'll see changes with more vascularization, more blood vessels coming into the tendon.
And so, in terms of gauging that kind of an increase in vascularization of blood vessels, is that something that's just a gestalt? Like you have a feel for, this is highly vascular, more vascular than it should be, or more issues. And it's just something you develop over time?
So the ultrasound, your tendon shouldn't have any vascularization in it from the get-go. There's a fancy button on the ultrasound that's a Doppler, and you put that on, put it over the tendon, and it starts lighting up.
Sure.
There you go.
And what other kind of, and actually we're going to sort of morph, I guess, the talk a little bit into it. And we'll talk a little more about cortisone injections, sort of the good, the bad, the ugly a little bit. But then what other kind of injections are you potentially doing utilizing the ultrasound machine? And what other procedures?
Yeah, so joint injections, tendon injections. I mean, staying to the Achilles tendinopathy, there's PRP, platelet-rich plasma. I don't know if you guys have talked about it before.
We've touched on it.
Yeah.
Take your own blood, spin it down to the platelets, healing factors, inject that back in. The idea promoting collagen and tendon growth, rehealing your tendon yourself. So that's a big one. That one probably would be better for Dre. More so off season because it can take 2 weeks to rehab it and get it back to feeling better.
So that's one of the other issues, right? It takes a little bit of time to get that kicked in. You know, and patients who ask me about it all the time, and kind of the spiel that I go with on or the kind of explanation I go there, which sort of makes sense to me in terms of the PRP is, you know, like if you have a cut on your skin, right, you bleed, right? And then what happens is when platelets come into contact with oxygen is they degranulate, they break down, and that initiates two separate things. One is it initiates a clotting cascade, so you stop bleeding, right? And number two, it's like a little bat signal, a little calling card for like stem cells and healing cells and whatnot. It also it releases a number of different like little healing factors, cytokines that get the healing process jump started. But you can see those little stem cells crawling to that area to start healing the process. So I think the concept was, let's concentrate those platelets. Let's spin it down, get a nice, and like inject that where we have an issue, and jumpstart that healing process. Get it to go.
And it works really well. For different tendinopathies, for Achilles, for hamstring, patellar tendon. Depending what you have going on, it's a good option. And
it does appear that that's where it works the best, right? Like, and we're morphing, right? Like, but it does appear that not necessarily for repairing a tear per se or regrowing cartilage per se. It doesn't appear to have a whole lot with that, but it does appear to very much help with tendinopathy.
Exactly. Bringing in that blood flow that already the tendon has the poor blood flow from the start.
Right. Yeah, I think that's helpful, right? Like those are the things that you want to see injected in those cases.
Right.
At least it's helpful. And so with that being said, right, I think, like we always say, our sources aren't really that. We get what we can, right?
Do what we can. It's only
and I think one public. Of the, I would say it's not overlooked, but one of those things that's overlooked with one of the downfalls of potentially any injection is just injection site issues, right? Potential infection, other things like that.
Yeah.
Again, our source right now, I'll say it, is Wikipedia for this one. However, it did say...
which means anybody
can edit it. It did say prior to the tear of his Achilles for Dre Greenlaw, he missed a regular season finale as the game was with an infection to his Achilles.
That's interesting,
And again, I couldn't find this anywhere else but Wikipedia.
Right.
I don't think it's that accurate if it is.
I can't put a lot of stuff.
Or if it was infected, he got a fluoroquinolone, and then he's really in bad shape.
Right.
Tell me about these fluoroquinolones.
Do tell.
Whatever are you talking about?
They're an antibiotic.
Right.
This is also theoretical too, but they can increase risk of tendon rupture.
Right.
Specifically
No,
in the first month. But
it is right there listed as one of the potential side effects.
So maybe.
Yeah. It is a legitimate thing, and it's somewhat notorious, right? Like it impacts your tendon, it affects your tendons, and there's a higher rate of tear within a certain window after taking those types of antibiotics. Now, if you're in a setting or a scenario where you need to take those antibiotics you need to take those antibiotics.
Right.
What are you going to do?
Like who's to say he's allergic to other ones? This is the only
Right.
one he could have.
That's
you know,
true.
like you know, again, we don't know his medical information.
Right.
But to play, just a speculation game.
Right.
Like if he was any general sick and had something needed it, could take him those antibiotics and had the weakened tendon. Or maybe he did get a PRP injection or a cortisone injection, had some issues with the injection site, could have had a little infection or something along those lines.
Right.
Could have clear up in like 2 weeks and goes and plays the next game or whatever the case is. Or, he didn't get any of these things and he just had a bad Achilles tendonitis and failed on him in the biggest stage. You never know.
Swinging it back a little bit to the ultrasound part of the equation, right? I know that another advantage there are other procedures that we'll sometimes do, and like I know Dr. Holmes is a big fan of something called the 10-jet procedure. There's another version of it out there as well, where you, like you said, you can actually measure the areas that are disorganized, where the tendon is the most tendinotic, or broken down or inflamed, and debride part of it and clean that area up and induce a healing response. There are other things we can do with the ultrasound. See calcifications, help break those up, sometimes with a needle, sometimes similarly with the 10-jet procedure. And it just sort of opens up the world there. Like, you can see the anatomy, you can see the inside of a person. When I was in med school at Georgetown, one of the first things they did, I remember early on, is they put up a picture of a chest X-ray, and they said to everybody, like who knows what this is, or who can read this? And we're all pre-med. No one has any idea. You can't. You have no idea what you're looking.
Right.
And you're like, I have no idea. And then they put up a picture of an X-ray of a rose, and they said, well, who knows what this is? And everyone, it looks like a rose. And then the basic idea was, once you know what it looks like, once you know the anatomy, it all makes sense.
Right.
So that's what the ultrasound gives you. You see the anatomy. Once you know it, you can see it, and it's pretty clear as day oftentimes. Anyway, all right. I think it makes us better. I think.
No, I agree.
I mean,
that's my whole job, so I agree.
Right? You have the power of ultrasound vision, not X-ray vision, but ultrasound vision, and you can see inside, and I think it changes everything, like you said.
So you can suspect a hamstring tear, and sometimes I use it myself. I'll use it for anatomy and knowing where the tip of my needle is. I'm not making diagnoses with it because I'm not quite facile enough. But for those people who are...
Yeah, not to toot my own horn, I saw what I was worried about was a glute med-min rupture. Got an MRI
I wouldn't
to
talk about
confirm.
specifics, but some different things that you could potentially see.
You could, suspecting a glute medius or some type of tendon rupture, follow up with an MRI for definitive, and some of the time, I'm right.
Right. So, so and it's a precursor, man. Like, you get to see, you kind of have an idea of what's going on.
Right.
Sometimes you're 100% definitive, or 100% sure, I saw it, there it is, I know exactly what's going on. Sometimes it's enough that now we need additional imaging, and we know enough.
Is there anything you would say that you would prefer ultrasound imaging? I know we're not talking about the injection part, but for diagnostics at least. So do you think, I'd rather see this on ultrasound versus X-ray, MRI, or other,
What do you got?
Where does it hold higher in the hierarchy?
For me, I mean, I guess more so for sports surgeons, is already repaired rotator cuffs. Ultrasound's better than MRI for that, for tears, recurrent tears.
I struggle with it, but yeah, for sure.
I think it's better for biceps tendon edema, like swelling around the biceps tendon. You see it more under the ultrasound than on the MRI.
I find so there's another big advantage to ultrasound over an MRI, and that's a real-time motion, right?
Yes.
So if we do an MRI, we're getting a static image, and so the person you pack them in there with all these foam and padding, and they're stuck in this tiny little tube, and you get a phenomenal picture of but you're not moving, and there's sometimes when we're looking for like a snapping tendon or something like that, and it can be very advantageous to have that, because you just put it on there. You see it move. You see
make it move and you see it.
It's wild to see it happening, to actually see it working. So if you're subluxing perineal tendons or snapping biceps tendon or what have you, there's a million of them out there, different areas, iliopsoas around the hip, and different things where you're looking to see is it clicking back and forth? What's causing the snap? And sometimes it just helps with narrowing down your differential. So let's say the click is coming from the hip. I wouldn't be good enough to be able to figure out based on the ultrasound if it's labral tear. I wouldn't see it's hard for me to definitively see labral tear. I can see the labrum. I would have a hard time diagnosing labral tear. But one thing you can do is look, and if it's not if they're snapping and it's not the tendon, it's probably the labrum. You know, like you can help sort of narrow down the diagnosis. I got you. We talked about another potential option where we weren't sure if maybe they jumped into a little bit of cortisone right in that same game.
Oh, yeah. So to talk more about the Super Bowl, there was a little scene there with the 49ers, George Kittle. He ran back, seemed to might have had a shoulder injury, something along those lines. He ran into the locker room pretty quick. Yeah. Came back and had a little sleeve on. Yeah. And we were speculating a little bit prior to the show of like,
what happened in the locker room?
Right. And I mean, last year's locker room scene of, we just suspected of what happened with Patrick Mahomes when he went in last year and had the ankle injury, came back, and he was able to run around like nothing was hurting him. Right. Interesting scenario. And then this year with the George Kittle situation.
Sometimes those shots work. No.
Right. So we were speculating if he got any injection or whatever the case, what he could have gotten or whatever those cases are. So that's kind of
what were your thoughts?
Probably a lidocaine injection. Quicker onset. I mean, it doesn't last for more than a couple hours, but steroid would take too long to kick in for it to be something like that.
So you don't need to have the steroid in there. Just numb it up with lidocaine or
enough to get through another couple hours of football. Then then you're hanging out in the offseason.
Especially if there was like an AC joint or something like that. We don't know exactly what it was, and again, sort of pure speculation.
Right.
Now it's funny. Like as we go through this conversation, as we're talking about it, I feel like the general feeling is that like oh, these are the worst, these are horrible things, and these lead to all these problems. But in reality, like that's not always the case. I mean, there's still a little piece of it, and it actually is always like mind-boggling to me sometimes that like for the right situation, for the right issue with the right entity, they're like magic. They are truly really magic. Like someone walks in and like I tend to reserve them for like a flare, right? Like arthritic flare. The person's having a ton of pain in their knee. They can't walk. You don't want to go to that well too often, and we say that frequently. But they come in, they can't walk, they can't do therapy, they can't do anything because their knee hurts so badly, and it's a really good way to calm that down. Like some people, like I felt better by the time I reached the front door.
That's how I present them too. It's only good when you're in a pinch or needing to put out a fire. It's great to get to tolerate PT to correct the biomechanics that you have issues with for longer pain relief.
And people do sometimes. I'll say that like all right, well, like sometimes people that coming in, they just want the shot. Like, can you just give me a shot? Yeah. But then I say like we should also do some PT. Yeah. And the idea being like, well, the shot will calm it down, but it's probably not the solution.
Yeah. If you don't correct what caused it, it's just going to come back again.
So let's get this calmed down, give you a window to fix the problem, then you're better.
Yep, right? Exactly.
I think that tends to be the kind of the better setting or the better use for these types of
to get them through like over the hump is just what you need.
Getting them over the hump.
Exactly.
And like with a lot of things of even like what we were saying before of like if he was in a situation where he was numbed up or either any case you don't feel it, you can do more things because you don't feel the pain and you don't have a limiting factor anymore. So if you don't have that pain in an arthritic knee, you can go through your day and do your job or go through PT and handle the workload that they put on you, and you can help hopefully correct those things that are putting you in that predisposed position or whatever the case is.
Right. The one place, and we talked about this a tiny bit as we were getting ready to get going. There's data out there that people will bounce back from a hamstring strain. We're talking muscle belly, faster. So it's not just dismissing or getting rid of the pain, so that you can do stuff, do the right stuff, but actually heal more quickly with cortisone shot. It's been used. I gotta say, I don't go to that well. I've had people ask for it, and I tend to be a little bit reluctant, even though there is some data to support it. But it just seems it runs so counter to everything.
Yeah, I don't know what to make of that.
Right.
Yeah, I think that's interesting, right? Because I mean, like I tell my athletes all the time is when they're dealing with any hamstring, it's just like those classic research studies when they do MRI of people who can return to play, the MRI, the hamstring is still damaged.
Yeah, typically takes delayed like 2 weeks behind actual healing.
Yeah. And so it's just like, that's interesting. So with that being said, my thought is like, kind of what we were talked about is, are you taking away the hypersensitivity of the hamstring? Because a lot of times when you get a hamstring strain, you're probably sprinting. You know, most of the time it's in a high velocity endeavor, so you don't feel it anymore. So you feel it, so you kind of have the courage to kind of push it through a little bit.
Right.
And then do you get those strength gains?
Because
you're doing more to the muscle, and you're getting like. So arbitrarily, let's just put it like, say you can only do a hamstring curl like 20 pounds because it feels a little tight, feels weird. I don't want to do that.
Right.
Okay, you numb it up, it feels better, everything calms down. Cranking out 40s, 50s, and then you get the strength from that.
Yeah. I would think all or nothing, right? Like the reason that's there is because the muscles basically telling you like, whoa, we're about to go, right? Like slow down, buddy. And if you don't have that warning sign, but at the same time, if it's not about to go, it's just an invalid inflammatory response that's giving you like a not a real warning sign, but then a false negative, so to speak. Then or the false warning sign. Then maybe working through it is the difference.
That's I don't know. It feels weird. I feel like
this is not risky. Pure science, right? Like this is speculation and kind of thoughts, and a lot of this stuff has really been looked into. And there are a lot of details on a molecular level on how this stuff works. I would not call it exciting conversation.
Right. No.
Definitely not.
And then we take it back to the 76ers, right?
Oh boy, here we go. Yep.
What's happening there?
So I just saw. It was funny. It kind of how it happened. My buddies and I were talking, and they were just like, "Hey, did you guys notice that Tobias Harris didn't play last night?" It was like last minute, and I was like, "Oh no, I didn't look." So I briefly looked into it, and he was
big win though.
Yeah, right. Big win.
Record on Tuesdays.
Yeah.
Monday night. Big win.
Monday night against the Cavaliers, they kind of pulled that one out, and they did pretty well. I mean, they made a splash, I guess, at the trade deadline. We got some new pieces.
Yeah.
I don't know how I feel about it yet. I got to see him play a little bit more.
I like the move. I felt like I was in the minority. Exactly.
Yeah, one of my good friends, he's been on the Buddy Hield train for a long time.
Right.
And he's been wanting to be a Sixer for a long, long time, and it made his day when they found out that it was officially happening.
Yeah.
So they ruled Tobias Harris out with hip impingement. Yeah. And then I was just like, oh, that's interesting. Can we inject it? Make it better? Get him back out there quicker?
Thoughts?
I mean, to get back out there quicker, but hip impingement is a tricky thing. I mean, not most people, but there's a lot of people who have hip impingement who aren't even symptomatic from it.
Right.
So the question is that what's causing his symptoms solely, or is there other stuff going on?
Right. Yeah. How old is Tobias Harris? Do we know approximately? He's probably 30, 31?
I think he's under.
No? Under that?
I think, yeah.
It could very well be. So all right, younger guy still. Define, or can you tell us a little bit more, like what is, if they say hip impingement, what is the underlying entity that people tend to have, which is hip impingement? Like
FAI, femoral acetabular impingement.
Yeah.
If that came out.
Right. Yeah. And then so what's a worry when someone does have hip impingement? What does that potentially lead to?
So your labrum's right around your acetabulum. So that impingement, the thought is that you're pinching that part of your labrum, and you can cause labral tearing.
Right.
I'm very familiar with that.
I know. I don't want to reveal any information out here, but sometimes that can cut short cycling careers.
It can.
Right. And so, like, I guess from a general fan standpoint, it's like, oh, that's okay. He's out for, he got a little bad hip, but it's like, you don't want it to become a chronic thing too, right? Because then it's like you said, it could cause the tearing of the labrum, and then you go down that train of a labrum tear and then surgery, and then coming back from that for a basketball player. And it's just like, oh, can we not have another big name go down under the knife for the Sixers, please?
But now I'm going to play devil's advocate, right? So there are a couple entities: frozen shoulder, adhesive capsulitis, right? Where the issue is the capsule. It's gotten inflamed. It kind of goes haywire. It becomes thickened and inflamed and kind of wraps down around the ball and socket joint. And everything that we do to make that better is directed towards loosening that up. So one, physical therapy and the ability to be able to push through some of the discomfort.
Yeah.
Two, getting rid of inflammation. And so in that scenario, the cortisone shot is actually part of the treatment algorithm, right? Like you're actually reducing inflammation, which is part of getting better. And I think there might be a little bit of a role for that in something like hip impingement. Again, it's one of those things, we don't want to go to this well too often. There are some side effects or consequences. But every now and again, I think it's worthwhile, like the one shot or a shot here or a shot there, to if they have some tightness in that hip and we're trying to stretch out that capsule and stretch out that hip, to reduce some of that impingement, which is happening, which is a mechanical structural issue. But if you can stretch out the capsule a little bit, maybe you can reduce some of that impingement. There is a role, I feel like you so you do that shot. One, they can tolerate the therapy better, and two, maybe it stretches out a little more quickly because you're taking down that inflammation.
Right. I agree. Yeah, that makes sense.
So and hopefully, the big worry here is like you said, right? Like this can lead, and we're getting a whole another conversation. But this can lead down this road towards labral tear, and then in a bigger, worse scenario, then you start leading to degenerative changes within the hip, right? Like symptomatic labral tear getting ignored, kind of chewing up the hip joint in and of itself. Can lead to a whole nother issue. Probably getting ahead of ourselves. Probably not the whole topic in and of itself.
Oh yeah, we could have done a whole episode of just that. But we wanted to touch on a bunch of different. I think we kind of threw a bunch of curveballs and all kinds of different things.
Right.
Just keep it rolling.
But in the I should say the two binding things, right? Like, or the injections, right? Cortisone shots and different injections that we can do. But then also the ultrasound, right? Like using that ultrasound, making sure. I joke around like. Cortisone shots actually work pretty well in terms of you don't necessarily need to be exact. You don't want to be in a tendon 100%, right? Like,
yes.
I joke around horseshoes, hand grenades, and cortisone shots, right? Like, as long as you're close, they tend to be pretty good.
Yeah.
But why not be perfect, right? Like why not get it better? Yeah. And that's where the ultrasound comes in.
Yeah.
And then there's another role for the ultrasound in those particular ones where there is a difference in some of these shots between an injection into the joint and an injection around the joint.
Mm-hmm.
Right.
And it's very hard to definitively get into the joint. Knees a little bit easier, like 80%.
Knees, 80% anterior lateral approach. I feel like every attending in our practice does it a little different.
Sure.
So.
Yeah, people find out the way, they get comfortable with it. They know the landmarks and that works best for them. Mm-hmm. And there are studies out there on what is the actual best way to do it. But in general, it's fairly similar. And then, but a shoulder or a hip, totally different ballgame, man.
Yeah, especially anatomy and just people with
variations.
bigger deltoids, bigger traps.
Yeah, I guess that changes up a little bit, huh? More meat to get through.
Mm-hmm.
For sure. So Dre Greenlaw tears his Achilles, mid to late 20s. Mm-hmm. We saw what happened with Ryan Howard, right? Mm-hmm. And his recovery is complicated by an infection. So all bets are off. Right?
Well, it makes you wonder, should he have done a non-operative Achilles course?
We're out there. We've talked about
that. Infections for the non-operative.
Absolutely less infections. Yeah. I mean, that's the huge advantage. That's the big difference, right? Like, and the pendulum is swinging. We've gone down that road. Right? The pendulum was, especially in this country, the pendulum was way up here.
Yeah.
Tore your Achilles, you got it fixed. Mm-hmm. And then in Europe, for the most part, they don't. Right, like so the pendulum for us is swinging back, and I think we still generally tend to fix them, but it is a very controversial topic at this particular point. And then there are a few things out there. There's a company called Arthrex, which I've mentioned multiple times here on the show, and they take advantage of something called, and we talked about it with Brant, and everyone was talking about it, right, with Aaron Rodgers. Was it Aaron Rodgers? Was that the big? Yeah, because he was trying to come back so quickly. Yeah. Kind of your PARS, your percutaneous repair, so it's small incisions, not disrupting blood supply, able to pull the tendon back together, kind of best of both worlds. Anyway, all right, I think we're going off the deep end here.
No, and I think it's one of those things too, and I think the interesting bad part about this is that he got hurt in his last game of the season. Fortunately and unfortunately, you made it to the Super Bowl.
Not even last game, regular season.
The regular season. So if he I didn't want him to get hurt, but if he got hurt week 18, he would have been already kind of taken. He would have been 4 or 5 weeks into the recovery.
If he's getting surgery,
right?
He would already had it.
And
if
so
not,
he's
already
a month.
Yeah.
So now it's middle of February. He's got 6 months till training camp, if not less. So he's going to be a delayed start, and so that means next year. I don't know. Does he play? Probably late in the season.
Are there any updates on whether or not he's going to surgical pathway?
I haven't seen anything.
Yeah.
I know that the only thing I saw about surgery option was his teammate George Kittle, who we mentioned before. He goes, "I hope he contacts Aaron Rodgers and does whatever he does so he can get back quick." Yeah,
right.
He was quoted saying that. So I was like, you would assume he's probably going to get the surgery, and
probably.
And I'm curious whether he goes, the famed Aaron Rodgers route and get like the speed bridge and all that other stuff.
Thing,
and to kind of go back to that, I think with that procedure, I think it got kind of popular around here with Bryce Harper. Right. He got it in his elbow, and that kind of brought light to the elbow of that. And then now with Aaron Rodgers, the national light is on it. So I think it's we'll see what happens.
Yeah. My suspicion is that he probably does get surgery.
Yeah, I would say so.
Yeah. And they probably go similar if they can. The tear has to be kind of in a reasonable spot for it. There are certainly some tears where it's not the ideal way to go.
Right.
But if it's the right kind of tear, my gut is that he's back. He's back sometime early in the season. I don't even think it's going to be late in the season. I feel like these have gone from these 9-month, year type injuries to, back down to 9 months, maybe down to 6 months. The Aaron Rodgers thing, I think that would have been exceptional.
Right.
As it is, was pretty exceptional what he was doing, but he didn't get to play.
Right.
Like as great as it was, and how close as it came, he too ran out of time.
Right.
You know what I mean? So I wouldn't expect it to be like he's there. He is, the first day of spring training.
Right.
Although I guess technically you never know. That's still more time than Aaron Rodgers had given it.
Yeah.
But I'd be surprised if he's not back within the first 3 full games of the season.
And I think with that too is I think his position makes it different. Right?
That is hard.
And we talked about this. I think we touched on it with the Aaron Rodgers episodes. Aaron Rodgers he has an athletic job, but he's not reacting as much as a linebacker does. Who their primary steps usually forward. They step forward and they have to react and they have to move side to side. They have to so instantaneous and different. Yeah. And I think it even changes a little bit in regards to we talked about Cam Akers before on the show. He was his own topic, and he has a recurrent, or he tore his other one this past year. So he's doing it, and he's generating force going forward and trying to move. But linebackers, they have to react and stop somebody. So you have to there's a lot more different unexpected stimulus that you have to respond to. Yeah. So his job's a little bit more, and I mean the numbers at least say that 7 out of the 23 Achilles tendons this year were in linebackers.
Yeah, ominous, right? It's an indication of just how much stress they're putting on it with all those changes of direction. What do you think? What's been your experience in seeing or treating patients who have had these tears, and after they recover, do you think the majority of them get back to 100% of what they were before they had the injury?
It would be more of a personal opinion, specifically looking at not specifically for Achilles, but any post-injury. There's a lot that goes into it. Sure. What comes to mind is Carson Wentz. He was never the same after he tore his ACL. I think if you don't have the right psyche about it, you're typically not the full 100% after an injury like that. You can't trust it as much. What
do you think? What's your take on it for these guys? So it's a roundabout way of asking, what do you think this means for his career?
Well, 2-part answer. I think if he comes back and does well with everything and he can get over it, I think he will come back and be fine. Yeah. I think what's also tricky with him is that something we didn't really mention is that the business side of it is that he's on the tail end of a contract, right? Yeah. So as a professional player, you got to get that extended or you have to get re-signed somewhere. Right. And then as a GM, you're thinking, take a risk on somebody who already has so.
But sometimes you can get that bargain deal.
Yeah.
Right?
So I think you could probably get him for cheaper, right? Which isn't good for him. It could extend his career, but then it's just an unfortunate truth about it's a business at the end of the day.
It's a business,
too.
right?
It's a business and a sport and entertainment and all that stuff. But I think the business side might haunt him a little bit. I think that the contractual stuff. Yeah. If the 49ers don't keep him, which I assume they will, he was really good for them.
Really good.
I assume
one
they
of
keep
the best
him,
defensive players, the best linebackers in football.
They potentially re-sign him and stuff. I think he'll do good and stay in the system. If he does the route of he doesn't get that contract re-signed and he has to go somewhere else, I think he starts to just dwindle out, do a season or 2 here, right? Dwindle over somewhere, be a practice squad, and kind of do that thing and just kind of
make his name, get back. I feel like it doesn't get enough recognition as a devastating injury, and I hate to say that. And everybody, people will prove you wrong frequently.
Oh yeah.
They'll get back, but lots of times they get really strong and they're really good, but it's not where they were before. Yeah. It's a tiny little step down, and he was really good. So maybe that tiny little step down is absorbed. Maybe that's not the difference for him in terms of having an excellent career, but sometimes that is a difference. These guys don't have a big margin of error. Right. You know what I mean? So if you lose just a tiny bit of explosiveness or just a tiny bit of control, I always worry that is that injury yeah, it's one of the. I feel like it's one of the more devastating injuries sometimes for a lot of these players.
That, and I think you can even eventually say that he had kind of like the above average career length. Like he's been in the league for almost 5 years now, right? That's not. I think that's a little bit above like the average, if you will. So I think that's also interesting too. Is that he's still young? He's 26. I still view that as pretty young, but like
I think it's incredibly young. But of course, I'm viewing it through different goggles.
But it's also just the nature of the beast. The sport's getting bigger, faster, stronger, and all the studs are getting younger and younger and younger. Yeah. So it's just like I don't know. Can he keep up with them?
I think he plays again. I just don't know if he plays at the same level.
I agree. Yeah.
Time will tell.
Time will tell.
Time will always tell. Think we're all good?
I think so.
All right, beautiful.
I think Brian wants us to check out.
Brian wants to check out. I think Brian wants to pour some milk tube first.
That's right. That's exactly what he wants.
So before we go ahead and close out our tab here, we just want to give a quick shout out to our sponsors, Protected. Protected is a custom bracing company that allows sports medicine professionals to have unprecedented access to 3D technology. With a quick 3D scan on your iPhone app, you can have a custom fitting brace arrive in as little as 48 hours. Protected is a tool that should be in every athletic trainer's toolbox. Learn more by heading to their website, www.protect3d.io, or downloading the Protected app in the App Store. The Energy Lab, the region's premier sports performance center and destination. Neck of the Woods Brewing Company is serving up these super cold beers and tasty sours. Sourfest May 18th, 2024, baby. Folks. Make sure you're there. And Timber Reel Productions helping us put this production together, video, audio. So go ahead and give us a follow and a subscription in our YouTube and Instagram channels, folks. We appreciate it, and we'll see you next time.